मरी गया 7 जन मरी गया પેકેજ આવ્યું 7 જણ મરી ગયા છે.
That's right. Yeah. 7 of the members of the committee are no more.
We are live on the YouTube. We'll start the meeting now. So welcome and good morning to all. Today we have Dr. Smruti Patel as our guest speaker. She is going to speak on acute encephalitis syndrome, infections and beyond. Dr. Smruti Patel is an alum of Baroda Medical College. She did her MD Pediatrics in 2016. Then she worked as assistant professor at Sumandeep Medical College. And then she did her postdoctoral fellowship in pediatric neurology from a very reputed college, and that is Christian Medical College, CMC, Vellore, in 2018-20. And since then, she has been working as a pediatric neurologist in Baroda, attached to KGP Children Hospital, and has her own clinic. Her areas of special interest are refractory epilepsy, pediatric stroke, neuroimmunology, movement disorder, and rare diseases, and especially DMD and awareness activity. So with this brief introduction, I request Dr. Smruti to start her talk on AES. Thank you, Smruti.
Good morning to everyone, and thank you very much, sir, for giving me the opportunity to give a talk in the reputed platform. And I'll be glad to share some information regarding the acute encephalitis syndrome with all of you. So I'll just start with brief introduction regarding what is acute encephalitis syndrome, first of all. So encephalitis means inflammation to the brain. So encephalitis is characterized by acute onset of fever and encephalopathy. What do you mean by encephalopathy? The sensorium can range from altered sensorium to the irritability and coma, and it can associated with or without seizures and with other neurological signs. So acute means within 14 days of presentation. Encephalitis means inflammation of the brain, and the syndrome, which is cluster of symptoms of fever, encephalopathy with or without seizures and focal signs. So this is a definition which is coined by WHO in 2008. So now what can be a etiology? So we know that acute encephalitis syndrome, the most common reasons are the infection. So infection is a very large subgroup of etiology for having a acute encephalitis. And in infection, there are various causes like viral, bacterial, rickettsial, malaria. But in infection per se, the most common are the viral, in which the herpes group of infections are most commonest one. But now, beyond infection, like other than the infection, there are so many other etiologies are getting diagnosed with upcoming investigations like MRI and advanced CSF investigations. So which are they are? So one is most commonest one is autoimmune encephalitis, and there are other immune mediated causes of acute encephalitis. In that, there are some demyelinating etiology, which is called a neuromyelitic optica spectrum disorder. And other than that, there are very least common causes of AES are metabolic etiology. There are some upcoming causes in which the child presents with a cluster of seizures and non-convulsive status, which is called a FIRS, that is febrile infection related epileptic syndrome. So we will discuss all this etiology case with the case-based presentation. So I'll just give you a brief regarding like what are the history we need to ask to diagnose the etiology. So we need to ask the thorough history of like fever. The child can present with the fever, headache, and other prodromal symptoms. And other than that, like the child will have, if it is a diffuse headache or some other focal neurological signs, we need to think about like child is having acute encephalitis. So in that, the symptoms like seizures, how it is, like whether it's a cluster of seizures or focal seizures or generalized seizures, Other than the seizures, if the child is having psychiatric presentation, which can indicate that the child can have autoimmune encephalitis, because in autoimmune encephalitis, the predominant symptoms are psychiatric presentations, and along with that, the child can have encephalopathy and seizures. We need to ask about if it is a very young child, you need to ask the parents about the his behavior, like how is the behavior. If it is very irritable child along with the fever, we need to think about whether the child can have meningitis before the child go into the altered sensorium. There are some etiological clues which can pinpoint to the particular etiology. Like if it is something kind of outbreak, the surrounding history of multiple children's present with a similar kind of presentations, where it could be viral etiology or a common outbreak. Recently we have heard about the Muzaffar outbreak, where the common source was the lychee, where the toxin associated child presented with the acute encephalitis syndrome. Other than that, we need to ask about the recent vaccination, where they can present with some amount of immune mediated encephalitis like ADEN, that is acute disseminated encephalomyelitis. We need to ask about the history of contact to the animals, consumption of the raw milk, and the child have went to some outing and had contact with the unchlorinated fresh water, then they can have encephalitis. We need to ask about the exposure to the mosquitoes, any risk factor for the immunocompromisation like HIV, and the similar history in the family to pinpoint about the metabolic type of encephalopathy. So these are some key points in examination to localize like where exactly they have involvement, whether it's just a brain, whether it's along with the meninges and brain, whether brainstem affection, or whether there is a signs of raised ICP is there or not along with that. And there are some general examination points where they can pinpoint to the particular etiology, like if there is an icterus, or so it can indicate about the hepatic encephalopathy. If it is there is associated with parotid swelling and orchitis, it could be associated with mumps encephalitis. If it is there is something labial herpes, it can associated with herpes encephalitis. Or we need to see about the bite marks like dog bites. So they can associate with rabies encephalitis. So I'll just start with my first case presentation, so to make it more interesting to the audience. So this is a 15-year-old boy who is first born to a non-consanguineously married parents, presented with us with history of high-grade fever, which was around 10 days of duration. And this fever was biphasic nature. So in the initial illness, the child had high-grade fever along with the vomiting and abdominal pain and loose motions. For that, he was admitted and treated for the dehydration and acute gastroenteritis. He was off fever, he was discharged, and again he was readmitted with the complaint of severe headache and reduced activity and interest in the surrounding. In the examination, he had meningeal irritation signs. So if we see, the child had some kind of vague symptoms, but with the severe headache, and in the CNS examination, the child had meningeal irritations. That means the child is having meningitis. So now what it can be the possible etiology? So definitely it could be infective, or either it could be aseptic meningitis, because there is no per se encephalitis in this child. So we went ahead, already the routine parameters and dengue plus enteric fever, all this blood investigations were done, which was non-contributory. And because of signs of meningitis, we have performed the CSF. In that, he found to have 50 cells, which is 90% of their cells are lymphocytic. So if it is, there's a cellular reaction is high, protein is normal, and sugar is normal. So this CSF picture, it can indicate it could be a viral, or initially the child have treated with the antibiotics, so it could be partially treated bacterial. Tubercular is very less likely, because usually in tubercular, the CSF protein should be very high, which is not there, and sugar is normal. The rest of the CSF, so wherever we perform the CSF, we need to send the, Grand Stain gene expert and along with that culture. And now, we send the BioFire. So usually the biofire are tests which can includes multiple bacteria and common viruses. So it is very easily available investigations which can perform which can detect the viral infections very rapidly. So in this child, he found to have that the child is antiviral PCR positive, and the rest of the investigations were normal. Whatever the antibiotics in the anti-meningitic dosage, even the steroids we have started, that we have stopped because the biofire report was positive. So he was treated conservatively, and he came out within a week, and child had attained pre-morbid level. So key learning points from these cases is the non-polio enterovirus as the most common meningitis worldwide in all the age group, whether it's an infant, children's, or either in the elderly age group. But the most frequent affected age group is up to 4 years, and that is also in the less than 1 month, that is newborns. It is more common in summer. And aseptic meningitis, that means you won't get much cellular. Usually in the aseptic meningitis, the clinical course remains benign. If it is very rarely, if the child is immunocompromised or in the less than 1 month, in that the child can have encephalitis where we need to treat them supportively. And the CSF PCR is the best way of diagnosis this encephalitis, and it reduces the hospital stay and long duration of antibiotic usage. Now I'll move to my second case. This is a male child who's presented on 45th day of life with history of sudden apnea and cyanosis while feeding and unresponsiveness. So these are the vague history where the child, you can think about maybe the infant have aspirated because it happened during feeding, but along with that, the child had seizures on the hospital admissions, which was multifocal seizures. Along with the seizures, he developed encephalopathy in form of reduced activity. He lost the visual fixation. He had stopped taking feeding from the mother, and which was lasted for a week. In a background history, child was born to be a preterm, and the birth weight was 1.56, and he was admitted in ICU for around 18 days because of he had HMD, that is the respiratory distress syndrome. And but throughout the course, his CNS was absolutely normal, and post discharge also the child was doing very well. And these are something new illness with which he presented. On examination, child was very lethargic. The general body movements were less, and the sucking was very poor. So what could be a possibility? Definitely, the first differential would be the CNS infection, because he has encephalopathy, seizures, and multifocal signs. And metabolic, which is very less likely because there is no consanguinity. There are no other sibling which is affected with the similar kind of illness. But we have worked up for the same also. So in the investigation, the routine parameters and ABG was normal. CRP was mildly elevated. We have performed the CSF to rule out the CNS infection, in which there were no cells, protein was normal, sugar was borderline, and culture was negative. So, and basic metabolic profile was normal. So we are not getting any clue. The CSF was absolutely normal. It was not suggestive of, in newborn, it is more common again, a pathogenic meningitis and viral. So that's why we have taken a poll that we will go ahead with the MRI. So the routine MRI images were normal, but in the advanced images, that is diffusion weighted images, the child was showing the diffusion restriction. That means cytotoxic edema in the particular areas of the brain. So just to simplify, you can see this bright area of the brain, this is a white matter, which is it's showing very bright. So in the ADC images, it is very dark. So it is suggestive that it is a cytotoxic edema, mainly involving a white matter of the brain. So whatever the area you are seeing here, so this is a brainstem, and this is a supratentorial structure, and this is temporal part of the white matter. This is supratemporal. So, so this is frontal, this is parietal, occipital cytotoxic edema. So this is something called a leukoencephalopathy, and it is very characteristic of parvovirus viral encephalitis, which is a kind of entero group of virus. So which is the child presented with the encephalitis. So this MRI is very particular about the parico. So based on the MRI, we diagnose the child is having parvovirus encephalitis. So HPV is most common important cause of sepsis-like illness and CNS infection in the infants, that is below 3 months of age group, and especially the preterm babies. And the transmission usually occurs by the respiratory or oral route, and the peak would be a summer. Not all the infants affects with this similar kind of illness, because there are many group of parvovirus. There are type 1, type 2, and type 3. Most of us are getting infected with type 1. Almost 100% of the human beings gets affected with HPV 1. But the type 3, almost 70 to 80% of the population gets infected with HPV type 3. So rest 20%. So if mother is not immune with the past infection of HPV, those infants were very prone to get the parvoviral encephalitis. So the root cause could be a respiratory or oral, and usually can present with the seizures and encephalopathy. Usually here the CSF and blood parameters remains normal, and but the tool of investigation is RT-PCR. That is, in CSF we need to send the PCR to diagnose to segregate a parvovirus. Here the treatment would be supportive. In the severe infection, IVIG can be effective to control the immune storm. So here we have treated the child with the IVIG and anti-seizure medications. After a week, the child was gradually improved, and this is a child's video at around 2.5 months, where you can see that the child's body movements, that general body movements, are absolutely normal. Child is making good eye contact, and with the verbal command also he's giving response. This is a video maybe around 4.5 months. So he's holding his neck in the prone position. So he's showing very mild motor delay. Otherwise, cognitively he was doing very well. And this is a follow-up MRI scan, which was all the whatever the area were affected was normal. Only there is a thinning of corpus callosum, means there is a white matter tracts are little thinned out. So maybe this is a child where he can have a future risk of cerebral palsy, mainly a motor type of where he can have diplegia. But other than that, the cognitively he is intact. I'll move forward with the case 3. This is a 18-month-old girl, which is a second born to a non-consanguineously married parents with a prior normal development. She presented with high-grade fever, reduced activity and communications, lethargy, seizures, and paucity of movement of right upper limb and lower limb. So this history where this paucity, that means, something kind of vasculitis event happened and she developed suddenly right hemiparesis. So fever, seizures, hemiparesis, so multifocal involvement is there, so and in examination also the child was having minimal conscious state, the pupil were reactive, she was having hypertonia, and right side the power was almost 1/5, and she had extensive planctus. The meningeal irritations when signs were negative, but of course the child is 18 months, so we cannot, the child won't show any meningeal irritations. So what could be a possible etiologies? So definitely the infection is the most common. In an infection also, we need to think about the TBM, because the course of illnesses was little long and child had hemiparesis. Usually in TBM, they can present with the vasculitis, TB vasculitis, and focal deficit, and along with the seizures. So what is the next line of management? Of course, we need to perform the CSF to say that whether it's a tubercular type of meningitis, or of course the MRI to localize to see the multifactorial involvement. So these are the etiologies we have considered, and we went ahead with the investigations. There was in routine parameters, there was mild transaminitis, and CSF, there were cellular reactions were this. Like, so in this age group, the borderline, so up to 10 cells is normal. So here the child is having 30 cells, so definitely it is abnormal. And it is 80% lymphocytic and 20% was neutrophilic. So, and sugar was normal and protein was also mildly elevated. So definitely it does not look to be a tubercular. Usually in tubercular, we will get very high protein and even the cells would be in the hundreds. So in the MRI, there are particular areas of involvement are there. So there is a perirolandic. So you can see this is insular area and this perirolandic hyperintensities are seen. This is a FLAIR images. So there is a this area and the temporal lobe and the insular cortex are involved. Even the temporal lobe is also showing the hyperintensity. So these are the area which is showing the cytotoxic edema, mainly the temporal lobe and the insular cortex and the thalamus. So, and there is also, after giving the GADO, there is a contrast enhancement. So this is the area where the herpes virus group of infection can be involved. So usually the herpes virus remain dormant in the Gazerian ganglion, which is a trigeminal nerve ganglion. So which is located near to this area. So wherever the child is immunocompromised and the virus gets activated, it gets sprayed to the nearby area. So which is a temporal lobe, basifrontal area, and the nearby area, which is a insular cortex and the thalamus, because the neural root is nearby to this. So these are the most common areas which is presented in the MRI. The MR angio was normal, so definitely it was not stroke, but it was a stroke-like mimic. So to confirm that, we have sent the CSF HSV PCR, and she was found to have positive with the CSF HSV1. The child was started on acyclovir because the child had presentation of kind of AES. So we have continued to give acyclovir for almost 21 days, and she was along with that treated with the anti-epileptic medications and IVIG. So IVIG, because this is per se it's virus, and along with that immunological storm, and because of that this areas are getting involved, and that's why we have given IVIG to control this cytokine storm. So learning points, HSV1 is very common cause of sporadic or non-seasonal AES, and the virulence and invasiveness depend upon the viral as well as host factor. It is not only viral. So if it is the host immune mechanisms are low, the virus can be, the virulence could be high. So HSV1 causes immune mediated injury and brain injury. It is not per se, it's viral. Delay in initiating acyclovir more than 48 hours, advanced age, and low GCS are poor, associated with poor outcome. So if any child or any human adult presents with the acute encephalitis syndrome with seizures or psychiatric presentations, we need to start with, and in the early MRI, if it is showing the temporal lobe involvement, we need to start acyclovir very immediately. We need to confirm with the CSF HSV PCR because it's a very gold standard test. And if it comes negative, then only we need to stop the acyclovir. But clinically, if there is a very high suspicion and if HSV PCR comes negative, we need to repeat it at the interval of 72 hours. The benefit of adjuvant steroids remains controversial, but there are some ongoing trials for giving the 7 days of steroid to prevent the further future morbidity or psychiatric presentations. There are some ongoing trials of, along with the injectable acyclovir, we need to give oral Welgen acyclovir for almost 3 months to reduce a future neuropsychological sequelae in terms of memory or memory deficit, future seizures, or cognitive impairment. I'll move forward to my case 4. She is a 1 year, 9-month-old girl who is a second born to a non-consanguineously married parents, presented with a normal prior development and no perinatal risk factor. She presented with initially first day seizure with low grade fever. On second day onwards, she developed the encephalopathy in form of irritable persistent cry, non-recognizing parents, and not able to sit or walk. On the fifth day of illness, again, she had a seizure. On examination, child was very irritable, confused, and she was not following the command. She was not interacting with the parents. She was not fixating well, and she was not tracking to light. Rest of the examination was normal. Only the tone was very high in the lower limbs. So the child had some areas of involvement are CNS and the visual tracts. So in the CNS, the child had encephalopathy. So that means the parenchyma has been involved and the visual tracts are involved. So definitely we need to think about the CNS infection first, because the child had fever, seizures, and all these presentations. We should not, we should also consider the para-infectious causes like ADEM, where also the child has similar kind of presentations. So to diagnose it, we went ahead with the investigation, because without doing investigation, it is not possible to confirm the diagnosis. So in the CSF was absolutely normal. The cells were normal, the normal protein, normal sugar, and even the viral multiplex PCR was negative. In the MRI, again, the routine MRI images were normal, but in the diffusion weighted, again, this is a child where there is a white tract involvement. You can see this bright areas of the brain. So there is the involvement of the frontal as well as parietal and occipital white matter, sparing this central sulcus, so perirholandic area. In the ADC also, the similar areas of involvement is there, but there is a sparing of central sulcus. So this is something, a terminology is called the AESD, that is acute encephalopathy with biphasic seizures. Biphasic means initially the child had seizure, then seizure free period, and again child is present with the seizures. So that is called a biphasic seizures and late reduced diffusion. So in the diffusion weighted images, we find the leukoencephalopathy, means white matter involvement, but in the later phase of illness, the child will present with the diffusion restriction. So it is called AESD, acute encephalopathy with biphasic seizures and late reduced diffusion. And it is now also called ALERD, that is acute leukoencephalopathy with restricted diffusion. Leuko means only a white matter involvement would be there. There is no gray matter involvement. So there are two types of ALERD. One is central sparing, where there is a central area of the brain. It would be a SPAD, and a diffuse variety where all white matters are getting involved. So the severity would be very high in the diffuse in terms of future sequelae and the outcome, where the prognosis would be very good in the central sparing. If you diagnose very early age, at the early phase of the illness, and if you start a treatment very early, then the outcome would be very good. But you need to keep in mind that this MRI, whatever we see, that involvement would be fine 3-4 days later of the encephalopathy. It would be normal in the early phase. And the treatment would be early IVIG and the methylprednisolone, because this is something kind of immune mediated. So here there is no role of antibiotic or antiviral. Here we need to give IVIG and steroid to control this cytokine storm. The child, during the hospital stay, she remained afebrile. With the treatment, the encephalopathy was gradually improved, but the child had only the visual tracts, because there is predominantly posterior involvement. So she had poor visual fixation on discharge, but gradually on follow-up, that also improved completely. So that would be on, we have discharged the child on the oral steroids, and she had complete improvement with that. This is something called ME-RS, which is mild encephalopathy with reversible splenial lesions. Here also child present with something kind of encephalopathy, but in MRI you will find in the splenium of corpus callosum. This is corpus callosum, this is genu, and this is splenium. There is a hyperintensity in the splenium of corpus callosum. So you can see this is in the SAG images. This is corpus callosum, and this is a splenial part where you will find the hypointensity. So the similar area in the diffusion weighted, this is a hyperintensity in DWI and low signal in ADC map, which is indicating there is a cytotoxic edema in splenium. So this is also something which it is not required any treatment. There is the child will, even there is no immunotherapy required, and child will improve by himself. So MRI tool is important here to diagnose the conditions and to stop all the type of treatment in terms of either antibiotic or antiviral, and we can tell the parents that child will improve within few days of life. I'll just move forward to the case 5. Maybe I don't know the time, but Satish sir, please give me the, you can tell me where I need to stop.
You have enough time, 10-15 minutes more actually.
Okay, sir. So I'll just move to the another case, which is non-infection cause of AES. This is a 4-year-old child who's a first born to a non-consanguineously married parents. He presented with high-grade fever, vomiting, and the altered sensorium within 24 hours of presentation. Along with that, he had a seizures and difficulty in breathing, requiring the ventilatory support. So similar kind of CNS infection type of picture. So GCS was very low. Child had spasticity, exaggerated DTR. There were no meningeal irritation signs. So this is very typical of viral encephalitis type of presentations. So we directly went ahead with the MRI to know whether it's something kind of infection or non-infection. So in the MRI, there were some areas of involvement. So there is, so here the predominant areas of involvement, this is our T2 weighted images where you can see this is thalamus. So medial part of the thalamus, it is showing hyperintensity, and along with that, there are areas where, in this flare images, you can see this area. This is thalamus and the insular cortex and the cerebellum. Sorry, this is a cerebellum, where is the cerebellar white tracts are getting involved. So you can see this hyperintensity in the cerebellum. Here also in the cerebellar cortex. So the areas of involvement are cerebellar cortex, brainstem, thalamus, subthalamic nuclei, and the insular cortex. But the predominant areas are the thalamic, which is the central areas are involvement. And there is some amount of cytotoxic edema is also seen. So there is a terminology called acute encephalitis, ANEC, that is acute necrotizing encephalitis syndrome, where this areas of involvement can be seen predominantly a thalamic involvement and multifocal areas of involvement where cerebellum and the insular cortex can be involved. The child had similar illness in the past with the fever and the seizure, and the child had stay of almost 1 week in the ICU, and that time also similar area of brains were involved, and the child was treated with the steroids and treated as an immune mediated encephalitis. So child was presented with a similar kind of recurrent acute necrotizing encephalitis. Why I'm telling necrotizing? Because in the diffusion weighted, there is a cytotoxic edema, and this is, you can see this is a cytotoxic edema, and surrounding there is a ring of vasogenic edema. So it is kind of trilaminar sign, which is very peculiar for the diagnosing acute necrotizing encephalitis. This is something called an immunological storm, where the thalamus will have a cytotoxic edema and surrounding vasogenic edema. So how we can diagnose? Based on the MRI and the supportive investigations, where the child can have minimal transaminitis and the CSF, there is a very high protein and normal cells. So here also in this case, the CSF protein was very high, 163. The cells were normal, and the culture was, CSF culture was absolutely, including the viral PCR, was negative. It is very important to diagnose very early phase, because if you diagnose very late and if you start a treatment very late, the prognosis remains very poor. So here there are some criteria for diagnosing acute necrotizing encephalitis, where the clinical presentations, if the child is meeting the clinical criteria of acute encephalopathy with the febrile illness, and in the blood investigations, as I said, the child can have serum, the transaminitis can be found out, and the CSF, there would be absence of pleocytosis and the high protein, and the MRI, it should be the symmetrical involvement of the bilateral thalami and supportive involvement, supportive criteria that could associated with periventricular white matter and the putamen or brainstem and cerebellar involvement. So he is meeting all the criteria. The child had encephalopathy, the CSF was very peculiar, and the MRI was very peculiar for the acute necrotizing encephalitis. So this is particular, I was talking about the trilaminar signs in the MRI. So you need to see the ADC images where you will find the central area of hypointensity, the surrounding very dark area, and the third layer, which is very again a hypo. The center area, it signifies the child can have hemorrhage. This is A, which is, it is indicates the bleed. The B is cytotoxic edema, and the C is indicating the vasogenic edema. So this trilaminar sign, it is very 100% significant for the acute necrotizing encephalitis. So the treatment would be again IVIG and the methylprednisolone. So we need to give a pulse course of 5 days of methylprednisolone followed by tapering schedule of oral corticosteroids. So this is a child where he came on follow-up. So child didn't have any cerebellar signs, though he had a cerebellar involvement. There was no focal deficit. The walk is absolutely normal. He can do a tandem walking. There was no ataxia. And the development was absolutely normal. So it's a beauty of MRI to diagnose the particular etiology, so that he received very prompt treatment, and on follow-up also in Kashiba he was stayed almost for a month, and he just in follow-up he was absolutely bang on normal. Definitely in the MRI there was some areas of the brain which is showing some cystic changes because he had a recurrent encephalitis, but with the receiving of treatment, he was absolutely normal. I'll just move forward with the another case. He is a 2.5-year-old boy who was first born to a non-consanguineously married parents and presented with cough, cold, fever, decreased responsiveness, and increased sleepiness, which is kind of like a hypersomnolence, not able to walk, sit, and speak for last 2 days, and seizures on the day of presentations. The prior development and the antenatal history was absolutely normal. In the examination, the child was awake, but he was not aware to the surrounding. In the video, you can see that the child is having non-purposeful involuntary movements. He has some amount of dyskinesia. He has some kind of choric movement and dystonic movement of upper limb. This upper limb is flexed, this upper limb is extended, and he had continuously have this mixture of dystonia, dyskinesia, and choric type of movement. He was not the parents were calling, but he was not showing any interest to the surrounding. He was not responsive anyway. There were no other focal deficit. So he was labeled as the child is acute febrile encephalopathy with movement disorder. So movement disorder, again, it could be associated with some kind of CNS infections, particularly viral. In virus also, either it could associate other than that, autoimmune encephalitis is also a upcoming etiology where the similar kind of presentation can be there. So to diagnose it, we went ahead with the investigations. So where the routine parameters were normal, The CSF was showing high cellular reactions, like 38 cells were there, which is polymorphic in nature, 80% were neutrophilic. The protein was mildly elevated, sugar was normal. So we can find this kind of picture either in kind of viral, or either it could associate with immune mediated etiology also. So in MRI, so no, previously we have talked about the HSV encephalitis, where area of the brain of the involvement could be, you know, this temporal lobe and insular cortex. But in this MRI, the MRI was absolutely normal. There were no such area of temporal lobe or other cortex or gray matter involvements were seen. So the MR negative child, so in MRI, there was nothing we are catching. So that's why we have sent the CSF autoimmune encephalitis panel to diagnose the CSF autoimmune encephalitis. And before we get the report, we have already started on IVIG and methylprednisolone, which is a treatment for the autoimmune encephalitis and other supportive treatment. Later, the child was very responsive to the treatment. You can see this in video. Now he's, you know, now he has started giving response to the verbal stimulation. He's now started making good eye contact. Those involuntary movements were gone. Though there was some irritability was there. He's asking for the need. He's asking for the food. And later the CSF NMDR came positive. So what are the criteria of autoimmune encephalitis? So there are some definitive criteria and the possible autoimmune encephalitis. So possible autoimmune encephalitis, where the clinical criteria, where the child will present with subacute onset, progressive illness. So subacute means less than 3 months progression, where the child can present with memory deficit, altered mental status, and personality change with or without psychiatric presentations, and along with the movement disorder. So at least one of the following should be there: new onset focal CNS findings, seizures which is not explained by the previous or known seizure disorder, CSF pleocytosis, and MRI suggestive of encephalitis. So here the clinical criteria is matching. The child had CSF pleocytosis, and there is a reasonable exclusion of the alternative causes like either metabolic or infective. We have already ruled out. So this is something called a possible autoimmune encephalitis. If the child in CSF, that is NMDR positive, it is confirmed autoimmune encephalitis. So there are 3 criteria: clinical, and the investigations wise CSF in the MRI. So treatment of the autoimmune encephalitis, the first line treatment is IVIG or plasmapheresis. So if it is a bigger child or the adult, we can go for the plasmapheresis. And if it is a very young child, we need to give the IVIG along with the steroids. If the child is not improving with the first line treatment, then the second line treatment would be rituximab, cyclophosphamide, and the other immunosuppressant like mycophenolate and azathioprine. This is my last case of this talk. This is case 7, who's 1.5-year-old girl, half-year-old male child, presented with cough and cold since 5 days, fever, and increased sleepiness. The prior history was normal. On the examination, child was drowsy but arousable, but he was not interacting with the parents. There was his dip-tendon reflexes were brisk and plantar was extensor. So the provisional diagnosis was acute febrile encephalitis without seizures. These are my differential: acute viral meningoencephalitis, ADEM, and the metabolic. In the investigation, the child CSF was normal. Only the cells were borderline, and the rest of the metabolic workup was normal. In the MRI, you can see there are some areas of involvement, gray area and the cortical involvement. So this is a thalamus which is swollen and the hyperintense, and there are some white matters and gray area are affected. You can see these are multifocal patchy white matter hyperintensities are seen. You can see in this flare images as well. There are multifocal white matter involvement are there, which are not showing any contrast enhancement. So MRI is very peculiar for the acute demyelinating encephalomyelitis, that is called the ADEM. And treatment here, it would be again a methylprednisolone and the oral course of steroid. He does not require usually ADEM, IVIG or any second line immunosuppression. They're very responsive to the corticosteroid itself. So this is an International Pediatric Multiple Sclerosis Society group criteria for the diagnosing the ADEM. So a first polyfocal central nervous system involvement with presumed inflammatory demyelinating cause, the encephalopathy which cannot be explained by the fever, and the brain MRI at least within 3 months of phase, acute phase, the child should present a diffuse polydemarcating involvement, predominantly cerebral white matter involvement, and deep gray matter lesions like thalamus or basal ganglia can be present. So in the MRI, you will get the thalamic and the white matter involvement, and along with that, a clinical picture, which are sufficient to diagnose the ADEM. They usually have excellent response to the steroids. The schedule should be 5 days of pulse course followed by the oral steroids. The second line usually would be IVIG, and the third line is rituximab and cyclophosphamide. But most of the children will give good response with the steroids. So here I'll just end my talk with this case presentations. I'm very happy to take the questions from the audience.
Thank you, Dr. Smriti. That was an excellent presentation with so many cases as illustration. So yes, we are open for any questions or comments from the audience.
Any spike during this epidemic in number of cases?
Sir, there are some immune mediated, like as we had COVID related illness. So COVID cases with the pediatric, they had very, various type of presentations like MISC, where the child have cardiological, CVS involvement. But other than that, we have seen the child presence with the acute encephalitis syndrome following the COVID also, which is kind of like immunological storm and demyelinating or immune mediated, different areas of the brain which is getting involved. And we have treated them with this.
Disconnection.
I think she's disconnected.
Yeah.
We wait for a minute for her to rejoin. I'm just trying to ask her.
Hello.
Smriti, you are disconnected. Yeah. Is it possible that you are rejoining, trying to rejoin?
Yes, sir. I'm just
Okay, we'll wait for you. Thank you.
Yes, yes.
Yes, she is trying to reconnect.
Hello.
Yes, Smriti, we can hear you.
Yes, sir. Sorry, sir. Actually, laptop.
Okay. It's okay.
Yes, sir. So post-COVID also, we have seen many patients who presented with such kind of presentations, and they presented with kind of encephalopathy. But yeah, there was no kind of like epidemic, but usually we have seen like in such a seasons where, in summer, many enteroviral group of patients which presented with aseptic meningitis. There are multiple number of patients who has similar kind of, meningitis with meningoencephalitis type of presentations.
Viral is more common than bacterial encephalitis.
Yes, sir. Yes, sir. Per se, virus is most common than the bacterial. And in virus also, the entero group is most commonest one.
Any other comments?
So, it's very, tricky topic, and like and acute encephalitis, it's very wide group of, area, and where now there are very upcoming newer cases, like other than the infections, many new etiologies are now getting diagnosed with the, diagnostic tools. So MRI, I would say it's very important tool, to perform at the early phase, so that, we can differentiate whether it looks infective or non-infective. And it should be very supportive in diagnosing the particular condition.
Very true, because in our times, now I'm talking about some 3 decades back, we used to see patients with fever, convulsion, altered sensorium. If it was not pyogenic, we would label this as acute viral encephalitis, and they would just succumb to their fate.
Yes.
We didn't have many options to offer to them to make a diagnosis and give any specific treatment. So things have changed actually. For people like me, who are little old timers now, have a lot to learn from people like you to differentiate between the common thing that we are seeing, and now we are making so many other diagnoses. So that was wonderful for all of us to learn so many things about AES.
Yes.
Any other comment? Hemant, you want to say something?
Yes. Doctor,
Yes, sir.
in my 30-40 years, I have switched off ventilators of 2 leukoencephalitis. One was a 6-year-old female in our Kashiba Children's Hospital,
Yes.
which the ventilation went on, the body was okay, and then we had to convince the patient relatives that she is no more. And one was my younger brother. He was about 40 years old. He had leukoencephalitis. So how many people go into the brain dead phenomena where you have to actually convince relative to switch off ventilator? And when?
Sorry, sir. I'm not getting your questions. Like, hello?
He's talking about leukoencephalitis.
Most of the encephalitis patients go into a coma, brain dead situation.
Yes, sir. Yes, sir. So usually the viral ones, yes, the viral ones are
ventilators continue the life, but the life has gone away. And then we had to convince the patient
yes,
that this is 21 days on ventilator and the person is no more.
Yes, sir. Yes, sir. So definitely something called a brain dead. There are some criteria for, to diagnose the brain dead.
We know the criteria. How many have you seen that in modern days? Has it increased or decreased?
No, sir. So it's purely based on the clinical criteria. It is not like, say, for example, EEG, and those are the not things like we need to diagnose the brain dead. They are kind of like supportive or atypical cases. Only we ask for the EEG. But usually the brain dead criteria are purely a clinical. So if the child is on any kind of sedation medications, we need to make him off those medications for at least 48 hours. And there are criteria for brain dead. Brain dead means whatever the clinical response, like the gag response should not be there, the pupillary reaction should not be there, the doll's eye response should not be there, the spontaneous respiration should not be there. So the capnography is one of the tool when you need to see the CO2 desaturation, how much it is. So based on the only clinical criteria, and there are some other clinicians also have, like there are 2 clinician opinions regarding the brain dead should be there, who should not be a treating doctor. Other than the treating doctor, to at least a field of like either a pediatrician or anesthetist or neurologist. So they can give a opine for the brain dead situations, like whether the child is brain dead or not.
Yeah.
My question
Dr.
is
Palak
simple.
Sah,
Has it increased or decreased in practice?
So yeah, in practice, definitely, sir, we are counseling the patients, to keep to make them off the ventilator. We are counseling that child is now no more. I mean, the brain functioning is not there. So definitely you can, discontinue the treatment, or if they want to go for the organ donation also, nowadays we are counseling them. If the child's vital systems are stable, that blood pressure is stable, so we can ask for the organ donation as well.
Yes.
So in a days, definitely, sir, we are counseling them for the brain death.
Smriti, there is a question from Dr. Palaksa. He's a pediatrician and allergist. Role of early plasmapheresis in autoimmune encephalitis, and further to that, he's asking after how many days of illness can one detect HSV PCR in CSF?
Yes,
And
sir.
anything to prevent HSV encephalitis?
Yes, sir. So for the autoimmune encephalitis, the first line treatment would be IVIG and or plasmapheresis. So plasmapheresis is a tool where, less than 4-year or 5-year-old boy, we need to put a central line, and then they need to perform the plasmapheresis. So less than 5-year, it is very cumbersome, and because we need to change the body, we need to calculate the body fluid. The body fluid ratio is very different. So less than 5-year, the plasmapheresis is not indicated. Above 5-year, we can go for. So we need to calculate the cost effectiveness. If the child is, if the weight is very high, and the cost of IVIG is going very beyond, so we need to give them options regarding the plasmapheresis. But infections and all those complications are very high in the plasmapheresis. So that's why we are very reluctant to go for the plasma. Usually we opt for the IVIG, because IVIG is very simple. We need to calculate the dosage, and only through the IV line, peripheral IV line also we can give. Because in the younger child, both the cost would remain almost same. So above 5-year, we need to check the cost effectiveness, and then only we can go for either of IVIG or plasmapheresis. Both are equally same in terms of response.
Right. The other question is regarding after how many days of illness can one detect HSV PCR in CSF?
So I would say in the early phase, like after 48 hours of illness, definitely we can detect we can isolate the HSV virus from the CSF. So it's a very gold standard. Whenever the child is symptomatic on a first day also, if we send the child would be, we can detect the HSV PCR positive. In a very rare situation, if the sample, it is not maintained a cold chain, we have not properly collected, or we have not stored, in that the diagnostics yield becomes very less. So if the sample collection wise, if there is error, or while sending or reaching to the, that particular lab, if it is not maintained that cold chain, then only the diagnostic yield becomes low. Otherwise, it is very gold standard test to diagnose HSV PCR. And as early as if the child is asymptomatic, we can diagnose, he can be positive.
So anything to prevent HSV encephalitis? The last question.
So there is no per se prevention measures.
There's no vaccine available for HSV.
Yes, sir.
Right.
So because I said, it is not only a virus which is important. There are host factors are also, like host immunity is also, there are multiple factors, not only environment. Because as I said, this is parvovirus case. The two siblings, there are two twins, only one twin is affected. One twin also had fever. He had also had coryza, but he was not had similar kind of presentation. So the host factors are also very important.
Very true. So thank you all for interaction, and thank you, Smriti, for accepting my invitation at a short notice. Thank you so much. It was so much learning for all of us. Thank you.
Thank you very much, sir. Yeah.
So we end the session here. We meet next Saturday morning again.